So let's discuss about a few of the points or the stations about regarding uh, trauma. So this trauma, it can be chest, it can be lumbar spine, it can be cervical spine, it can be pelvis. So the stations can be just like a young male having road traffic accident by the motorbike. Now is hypotensive and tachycardiac. So this patient is having tachycardia, hypertension in shock. So how will you assess this patient? So first is question will be assessment. So all these trauma patients, it has to be assessed via acute trauma life support, ATLS. So ATLS protocol, you have to keep on all these cases, ATLS protocol. So what is the general principle of ATLS? It depends upon these general principles have got A, B, C, D, E. Airway is about A is airway along with this stabilization of spine, cervical spine. Then B is breathing, C is circulation, D is check the disability, E is exposure. So you have to check about this. Then after primary assessment, you have done this A, B, C, D, E. Primary assessment, you order some investigations like chest X-ray. This is the commonest investigation. And X-ray findings, you have to look for tension pneumothorax. First of all, tension pneumothorax, fracture of the ribs, then shift of trachea and mediastinum, collapse of the lungs, or if you see surgical emphysema or costophrenic angle obliteration. So these are the things you see in the X-ray. If the X-ray visibility is clear, whether it is adequate or not, you have to check it. Then if you see there is pneumothorax, first management will be, what will be the first thing is needle thoracostomy. You have to put the needle in the fourth or fifth intercostal space anterior to mid axillary line, and then insert the chest tube, that is definitive. Then check the patient, do the X-ray after insertion, confirm it. So if the patient is in shock, BP is low, shock, you have to define the classes of shock, class 1, 2, 3 and 4. So this is about 750 ml loss, this is 750 to 1500 ml, this is 1500 ml to 2 liters, this is more than 2 liters. So what is the percentage? This is around 15%, this is around 15 to 30%, this is up to 40, 30 to 40, this is more than 40% of the blood. So what will happen for the pulse rate? So there will not be much difference in first, it can be less than 100, then pulse rate is increased to more than 100. So it remains 100 is the pulse rate. So what happens in class 2, pulse rate will be above 120 and here it may go above 140. So what will happen for the blood pressure? This is important thing. In first class 1 and 2, BP will be stable. So increasing, BP goes down. So what then happens in respiratory rate? So in RR also, normally it is 14 to 20 up to 20. Then here in class 3 and class 4 shock, it may go to 30 to 40 or more than 40. So pulse rate more than 140, respiratory rate more than 40 or 30. So again, the very important finding is urine output. So what will be the urine output? So there will not be much difference in 1 and 2 again. So here it is around more than 30 ml, 20 to 30 ml. Here it goes down 5 to 15 ml, and it is less than 5 ml per hour. So this is the important. Then symptoms may be normal, confused. So base deficit, in this manner you have to see. So in which grade does the BP starts dropping? So BP drops after here. This is the point. How will you manage the circulation? Now if the patient has got some bleeding inside, now here is management of circulation. So this is A, B and C. So this is important. Any question can be coming. So you have to check for source of bleeding, whether it is internal or external. 2 large bore cannulae has to be inserted. Take blood from one and send for investigation. Full blood count, urine electrolytes and ABG, blood group, blood glucose level, all this. Cross match, and 4 units need to be ready. Then what you do? Resuscitate. 1 liter Hartmann. Then consider BT, monitor urine output, check capillary filling. So how will you monitor the response? So monitor response by BP. First of all, it has to be transferred to HDU. Measure, check the blood pressure, capillary filling time, urine output, mental status. If there is no improvement, it can be shifted to HDU. Then no improvement, patient needs to be consultant HDU register, central line. Then you go for central line and blood according to HB level and start inotropes to improve the BP. Central line was done and show the diagnosis. Showed following. What is your diagnosis? CT is done. If patient is done CT, any injury, whether find out liver, spleen, organ injury. So there again different liver injury grades. It depends upon laceration, hematoma. So how is the 1, 2, 3, 4, 5? Then if laceration or hematoma, so less than 10%, first of all check for hematoma. So 2 is 10 to 50%, 3 is more than 50%. And laceration, it has to be laceration less than 1 centimeter, less than 10 centimeter, and it is more than 10 centimeter. So 10, 15, 1, this you have to remember. Grade 4 parenchymal disruption, more than 25% to 75% parenchymal disruption. 5, there is 5 and 6 is very big, major part of the liver is injured. So again, what you do with the liver tear, how to manage? So first of all, if it is in between this range, 1 to 2, can we manage conservatively? So conservative. Grade 3, if the patient is stable, it can be managed conservatively. 4 and 5, vascular injury and all that, you have to go for exploratory laparotomy, then packing, suturing and all that. So VASCT is the good, because if the patient is stable, unstable patient, you have to go for fast. So then you can go for damage control surgery, just do packing and blood. So which type of shock is, say, it is either cardiogenic or obstructive shock. neurogenic, most likely neurogenic shock in the patient is tachycardia. So what will we look for a fast scan? So fast scan. So if you see, this is an abdomen, and here is the sternum and ribs. So fast scan looks after right upper quadrant, left upper quadrant, pelvis, and pericardium. So here it looks for the cardiac injury, pericardial collection. Right upper quadrant looks for the liver and around it. Left upper corner for the spleen, and pelvis checks for the any organ to the pelvic injury. So if you are suspecting another injury of cervical spine, so the important things which you need to note, the girl fall from bicycle, neck injury, this will be a stem. Such type of stem is there. You have to think of neck injury. Again, you have to start with ATLS, A, B, C, D, E, airway plus cervical spine stabilization. This is more important here. So breathing, what you have to see for breathing, you have to check for the respiratory rate, excessive muscle restriction, chest movement, cyanosis. Then look, feel, look, listen, feel. So in breathing, look, listen, feel. So look, listen, feel. So listen by stethoscope, feel by central and all that. Then what will be the breathing problem in the patient? What is the effect on the lung? So what happens in cervical spine injury? There can be, patient may have shallow breathing, and because of possibility of phrenic nerve, because you have to think of phrenic nerve, C345 keeps the diaphragm alive. So effects on lung is decreased ventilation, collapse, lung atelectasis. What does the patient have? Respiratory depression. So paralysis of intercostal muscles can be there. The patient can have injury to phrenic nerve. It can be CO2 retention or brainstem injury. Because sir, so what investigations? So which investigation you will do? In this CT and MRI, these are the important investigations which need to done. CT is, now if you see any of the investigation, like X-ray is given, cervical spine X-ray is given, and you see MRI is done, and these are the spines. Now you have to check for injury on the X-ray. If there is injury at this site, cervical spine 2 or something, or cervical spine 5, so what happens? C5 injury, if it is shown on the X-ray, it's very significant because the nerve is phrenic nerve, C345, and that may lead to diaphragm paralysis, and if lead to bleeding, breathing will be affected and collapse, leading to respiratory acidosis. So this can be assessed by acid blood gas, ABG, arterial blood gas analysis. Use respiratory acidosis. So what will happen here? The pH will go down, pH will go down, PCO2 will increase, and bicarbonate, and there can be hypoxia. And this is type 2 failure. Type 2, what will happen? PO2 less, PCO2 raised. So there is hypoxia and hypercapnia, both will be there. So this patient, where there is partial paralysis, you have to either put ventilatory support. So this patient may need BiPAP, bilevel, or non-invasive NIV, non-invasive ventilation. So bilevel positive airway pressure, If you may be given APG and partially compensated apicana, what will you do in here? So good ventilation, I have research based to fixation for neurosurgery. What thing will you do before? So now patient has got cervical spine injury. That patient needs neurosurgery. So this patient needs triple immobilization and consent. First is consent, triple immobilization. How it is done? Cervical collar, sandbags, and stripping. So you have to think of then disability. Now neurological assessment. Neurological assessment. So because patient spinal cord is incomplete, now you will do different types of spinal cord injuries: central, anterior, brown sequard, posterior. So basic thing in central will be upper extremity will be more than lower extremity. This is the basic thing. Anterior cord syndrome, injury to the anterior spinal cord, direct osseous compression, anterior spinal injury. So what will be lost? Anterior cord. So lost will be motor, and pain, temperature. What will be preserved in anterior cord? Proprioception, vibration. And brown sequard, same side, ipsilateral motor loss, motor, proprioception joint, and opposite side, pain, temperature. Posterior is very rare, proprioception will be lost. So this will be lost, proprioception. First line of management in now cervical spine, you have stabilized everything. Which drugs you will give is dexamethasone to prevent further compression. Consequence of effect in breathing. Shallow breathing will lead to hypoventilation. There will be no lead to lung atelectasis and collapse. So how to manage this respiratory condition in patient? Already 100% oxygen is given and you need to manage it further. So here you need intubation. So 100% oxygen is given, stabilization. What will you do with the patient after discharge? Now patient is managed, surgery is done, so patient is discharged. So now this patient needs rehabilitation, physiotherapy, spirometry, tape stocking plus DVT and neck pressing. So this about the cervical spine injury. If you get lumbar spine, so this is the lower level lumbar spine. It can happen when the patient is having any road traffic presents with decreased BP, paraplegia, or sensory loss, lower limb. So what are the different scores? Which scores? This is road traffic accident. Which scoring? It can be any mechanism. Which scoring mechanism you will use? The most common is Glasgow Coma Scale, Injury Severity Score, Abbreviated Injury Score, Trauma Injury and Injury Severity Score, TIIS, TIS, Trauma Injury and Injury Severity Score, or Revised Trauma Scale. So these are the different scores: Glasgow Coma Scale, Injury Severity Score, Abbreviated Injury Scale, Trauma Injury and Injury Severity Score, Revised Trauma Scales. So this has again to be managed by ATLS protocol, going for ABCD approach. What investigations in the lumbar spine is MRI is again the gold standard, or CT scan can be done. What are the findings? If you see a lumbar spine, you will get see the picture of any of this, and there is a spinal cord inside, and there is compression, and you have to just measure the level of vertebra sacrum. So you get a L3 or L5 spine fracture and retropercussion cord compression. What other injuries may be associated? Lumbar spine, what can be the other injuries? It can be chest, it can be pelvis, it can be long bones, it can be abdomen. So there can be possibility of any of this. So what type of shock is there? In this case, there is hypovolemic blood loss, can spinal, and then can be neuro. So any of the shocks can be there. So first of all, how will you manage the circulation? Again, the circulation has to be managed. All these circulations, ABC circulation has to be managed by wide bore, cannulae, Ringer, Hartmann, BT, comment the fluids, urine output, then monitor all the things, monitor it by heart rate, BP, capillary filling time, urine output, mental status. So what are the complications associated with spinal cord injury? If the spinal cord is injured, so what can be there? Early you can find spinal shock. This is a very common thing, spinal shock. So what happens in the spinal shock? Temporary loss of reflexes below the level of injury. Reflexes below injury are lost. Neurogenic shock. BP goes down because sympathetic tone is suddenly lost. Respiratory complication. If breathing muscles are involved, bladder and bowel, this control will be lost. If at T6 level there will be autonomic dysreflexia. Then there can be the late complications. So this can happen is a lower motor neuron, it is paralytic. Upper motor neuron, there will be increased muscle tone and spasticity because total lower is happening. There will be chronic pain. So this is late. Chronic pain, patient is persistent. Or there can be osteoporosis. There can be deep vein thrombosis, urinary tract infections. Patient may go in depression, anxiety, unable to walk, pressure sores, sexual functions. So these are the spinal injury. Patients having spinal injuries are bedridden for longer time. So many things can complicate. So each complication has to be managed. So how will be the management of all such complications? It depends upon rehabilitation is very important. This patient is having who needs crutches, physiotherapy, transfer, ulcers, sores, bladder, bowel, and all care has to be done. Muscle wasting has to be treated. Exercise, physiotherapy, erectile dysfunctions needs supportive therapy. Osteoporosis needs bisphosphonates, vitamin D, calcium, and neuropathic pain has to be on pregabalin or gabapentin and some types of drug. If no erectile dysfunction, no erectile dysfunction, so level has to be because hypogastric plexus are intact. How to know patient is having neurogenic shock? What are the signs of neurogenic? It has got again a triad which involves there is low BP. It has to be low BP and low heart rate, and there is decreased temperature. Classic triad. Blood pressure is going down because sympathetic tone is lost and vagus parasympathetic is acting. This is because of vasodilatation. Then heart rate, again sympathetic tone is lost, vagal tone is increased. Then, because of vasodilatation, core hypothermia and warm, dry skin due to sympathetic nervous system response to vasoconstriction. So, what is there in brown sequard syndrome? Again, brown sequard. This is hemisection of the. This is the posterior cord. This is the anterior cord, and this is hemisection. So, ipsilateral motor contralateral pain temperature. Motor sensation, pain temperature on the opposite side. So in spinal shock, what reflex would be present in spinal shock? So bulbo cavernous. This commonly asked question, spinal shock, bulbo cavernous. How to manage a case when seen in emergency room? So again, emergency room, you are getting this case, neck immobilization, ATLS protocol, fluids, noradrenaline, all this. So another case in trauma, you get a patient is having 29-year motorcycle road traffic accident, fracture femur and tibia, flank ecchymosis. So what happens? Flank ecchymosis, tenderness, pain, lower abdomen and blood at urine meatus. So you see blood at the meatus. This is a classical example where the patient has got some sort of injury, and you see the X-ray. You will be getting an X-ray where there is this the pelvic bone, two blades, and normally this pelvis has the pubic symphysis should be in the center. So if you find this is the extremity. If you find this is totally disrupted and this is sacrum in the center, so you have to read the X-ray. What injuries would you suspect? So whenever there is disruption of the pelvis, you suspect basic bladder, urethra, renal and vascular. Again, ATLS protocol, what is the priority in multi-trauma patient? So what will be the priority? You get a multi-trauma, polytrauma. This is polytrauma. First thing is cervical spine, because there is breathing is important. Secure the airway. You need to secure airway. Look for any foreign body or anything. Patient is breathing, consciousness is there. Airway, breathing. Then you need circulation. Again, for circulation, you have to check the pallor, capillary filling, blood pressure and voltage. Then give the patient, do the ABCD, then disability and ease exposure. So the same thing. So X-ray pelvis is done, and then you have to read the findings. What is the possible? So it is dislocation of sacroiliac joint and disruption and book open fracture. What type of fractures there can be? Pelvis has got side to side, that is compression, upper and below compression, or AP lateral vertical shear. These are different. Commonest is the lateral compression is the commonest. Then what type of shock these patients have? Definitely there is hypovolemic volume, lot of blood loss, around 2000 ml. So these are class 4 type of shock, more than 2000 ml is lost. And now you will get a pulse pressure will be narrow. So body tries to maintain diastolic BP and systolic is falling, systolic BP is falling down. So it is a difference between diastolic and systolic. Again, it will be managed by massive blood transfusion protocols. You give resuscitation by the crystalloids, stabilization long bones, and laparotomy has to be done. These patients need monitoring by heart rate, blood pressure, capillary filling, urinary output, and mental status. Then, if the urethral injury is suspected and you get blood at the urinary meatus, urethral injury. So what you do is antegrade cysto-urethrogram or retrograde urethrogram. You just put a catheter if you are suspecting the injury. Suppose this is the penis. tip of the penis, and this is the urethra, and this is the bladder. And after injury, if you suspect this is urethral rupture, so what you do, this is retrograde. You put a catheter, soft catheter here, and inject the dye and see the cystourethrogram, whether it is going up or there is leak. This is retrograde. What is antegrade? You put a catheter inside the bladder, suprapubic catheter, put the dye inside, and you check whether it is passing or it is spilling out. So this is retrograde and antegrade. And Foley's has to be avoided. Foley's is never done. Why? Because when there is blood at meatus, hematoma, perineal hematoma, it can patient if having bleeding tendency, prostate, high riding on PR, meatal stenosis. These are things where police have to wear. What should be done? Call neurosurgeon. He will do suprapubic. He will do catheterization. This is catheterization. How suprapubic catheterization is done? So this is the abdomen. You get a penile injury here. So the urologist is passing directly catheter from above, so that bladder urine will be drained out. So that is suprapubic. So what are the different type of catheters? So this is the question. It can be condom where you doesn't enter, condom catheter. It can be straight catheter. It can be cowdy tip catheter. There can be two-way or three-way Foley's catheter are there. Two-way is normal use, three-way is for the irrigation. There can be silicone catheters. There can be supracath or suprapubic catheter. There can be Nelaton catheter for irrigation of the clots. So how will you manage a pelvis fracture? The patient is having pelvis fracture. Now this is, so binder has to be applied to prevent taxanemic acid has to be given to prevent bleeding. If you open it, then do packing. Definitive surgery can be by external fixation. Bladder injury or urethral injury has to be managed by urologist. Abdomen or anal wounds has to be managed by a surgeon, consultant, surgeon doing laparotomy, wound debridement and colostomy and all that. So would you order whole body CT scan? Because patient if having high trauma injury, you need a scan. What are the advantages of whole body CT scan? Early diagnosis, survival rates, high disadvantage, exposure. So this was about the trauma. Then another thing you can get maybe in the trauma is that a 60-year chef, he was working in the hotel, he gets 60-year-old man, he has been trapped in the kitchen for more than 30 minutes and this was brought in the emergency room, heart rate is 120 and blood pressure is 90/50. So this patient has got burn, and so burn is covering chest, abdomen. So this is important. Here what you have to notate, cover the then right and left lower limb. So lower limbs, right, left, and upper limb only right. Some soot around the mouth and nose. Asking friends. So, and how is the type? You see erythema and blisters and he is able to jump from the window first floor. So blisters are there. Now, which is the type of burn? It is partial thickness because patient is having blisters and erythema. This is showing towards partial thickness. And now to calculate. So the basic formula to calculate, you have to remember in the mind, this is the face and this is the neck. Then you have to just remember right upper extremity, left upper extremity, complete, then anterior body, then lower extremity. So the rule of 9. How is the rule of 9? So just divide this. This is 9%, this is 9%, this is 9%, this is 9%, this complete is 9%, this is 9%, this is anterior is 9, posterior is 9, anterior is 9, posterior is 9, and complete is 9. So you get this in this manner. This is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So this is 99%. And perineum is 1%. In this manner, when there is lower extremity, so complete right lower extremity, right and left. So lower extremity, if this is right, it is 18, 9 plus 9. Lower extremity, right, left. Again 9 plus 9. Both lower extremities. So he has got burn. Right upper extremity is only 9. Then chest and abdomen. So anterior, so this is 9, this is 9. So how many 9 here in burn? 1, 2, 3, 4, 5, 6, 7. So 9 into 7, that is around 63% burn. So you have to calculate this patient is having 63% superficial to deep burn. So partial thickness burn. Now, how to manage the patient? This patient, again, it has to be managed by ATLS protocol. Now, what happened? This patient is having A, B, C, D. So, airway, you have to check basic in this signs of nasal or burns in the inhalation injury, facial, airway edema, hair, soot, all these, they need intubation. This patient needs intubation. If you're suspecting, then what is about breathing? If the patient is already talking and burn over the chest, tickle, and then patient needs intubation. Then circulation, you have to put 2 large bore cannulae, one sent for specimen, one for the blood sampling and all the investigation, full blood count, KFT, electrolytes, albumin, all that. And from the other, you have to calculate the crystalloid, how to resuscitate crystalloids. This is again important. Crystalloids has to be given. So Parkland formula, what you have to use is that it is actually now the present Parkland formula 2 and 2 into total burn surface area into body weight. So if the patient is having 63% and body weight is around 50 kg or 70 kg and 2, so that will come into roughly around 8.5. So among these first 8 hours it has to be 4,200, and next 16 hours it should be 4,200. So this is resuscitation. Within first 8 hours you have to give, and remaining this you have to give this much. So this patient needs, if it is electric burn, you have to go for 4. Then again, what is colloid or crystalloid? Crystalloids are preferred in first 24 hours. Colloids can be given in maintenance. Could you give patient colloid after 24 years? It can be given to correct hypoalbuminemia. Mention 5 complications of burns. What can be the complication after burns? It can lead to shock first, sepsis, ARDS, electrolyte imbalance leading to renal failure, then DIC, or it may lead to breakdown of the nerve. 4 days patient tachypnea, respiratory oxygen saturation on the room air. What happens after burn? Patient has got respiratory rate is increased, oxygen saturation is going down, X-ray is done. So this patient is X-ray chest is again. If you find ARDS, how to diagnose ARDS? A burn patient may lead to ARDS. So bilateral pulmonary infiltrates, bilateral pulmonary infiltrates. So this will be there, leading to ARDS. And what is the definition? Is the acute diffuse inflammatory. Definition is diffuse inflammatory swelling of inflammatory form of the lung injury. So there can be hypoxia or hypoxemia. Lung compliance will go down. Pulmonary infiltrates on chest X-ray, non-cardiac. Pulmonary artery which pressure should be less than 18. So partial pressure of oxygen divided by FiO2 should be less than 26. So the causes of ARDS will be other, can be sepsis. So it can be infection, gastric aspiration, head injury, pancreatitis, burns, trolley, and all that. So how will you manage ARDS? Again, ARDS has to be managed in ITU, intensive therapy unit. Patient needs, because the respiratory support is important. Here the patient needs positive and expiratory pressure, PEEP ventilation. So 5 to 15 ml, because to prevent alveolar collapse. So it gives oxygenation and improves the cardiac output. Here you have to give steroids, hydrocortisone, low dose steroid has to be given. Manage the sepsis by giving antibiotics, identifying the organisms. Hemodynamic fluid management has to be done. Fluid calculation has to be done. Output has to be monitored. Swan-Ganz catheter can be passed to maintain the and positive inotropic. And then you have to manage nutrition support. Patient needs nutrition and all that. Prevent venous thromboembolism by TED or low molecular weight heparin. So this has to be started. Prevent gastric ulcers by giving prophylactic anti-proton pump inhibitors. So ARDS has to be managed into ITU. What are the long-term sequelae? So it can lead to fibrosis of the lungs and lead to decreased lung compliance, and these patients needs lead to pulmonary hypertension afterward. So ARDS severity, ARDS, and ARDS can be evaluated by one called as Berlin's criteria. So it can be mild, moderate, and severe. So it will explain survival rate. So it depends upon PaO2 among FiO2. So it is 200 to 300. It is mild. So mortality is around 27%. It is less than 100 to 200. Mortality is 32%. If it is less than 100, then mortality is 45%. So when you need to transfer a burn patient, burns transfer, which patients you will transfer to the specialist burns unit. So immediately stabilization and transfer. So hands, perineum, chemical, electric. So what are the signs where you suspect inhalation injury? So this can be asked. Inhalation, again it can be soot, sputum, nasal, hair, burnt, face, voice, tongue, edema of the tongue, lips, edema. So another common thing, which next station, which can you are getting in the trauma patient, a 28-year-old male person around having road traffic accident, and he has got crushed, and he was unobserved for a long time in the orthopedic ward. The investigation showed increased creatinine level, increased urea, and blood in urine dipstick. So what you suspect? This patient, unattended patient, immediately you have to suspect compartment syndrome. It is compression, or it can be rhabdomyolysis. Lot of muscles are crushed, and you can suspect acute kidney injury. What is compartment syndrome? So it is P's, 6 P's. Again, what is there? Pain out of proportion, pain not relieved by the analgesia, pain on passive, then swollen paresthesia, pallor, pulselessness. Patient sustained complete loss of motor. Suppose motor, spinal cord injury, and sensory, lower limbs. Now patient has spinal cord injury and both are lost. Now how will you suspect? Now major compartment pressure. Absolute pressure has to be more than 30 millimeter of Hg. If it is delta pressure is diastolic plus compartment, 30 millimeter of Hg. Difference between diastolic and compartment pressure. If it is more than 30, absolute is general normal pressure. If the diastolic pressure and compartment pressure more than 40, it is compartment diagnosis. Actually clinically, what is normal compartment pressure? Normal compartment pressure is 0 to 15. Absolute means 30, and difference in diastolic. What would be action if you really suspect? If you suspect compartment, what will be the immediate action? Again, that compartment needs immediately fasciotomy, decompression. If the patient is alert and capable of returning information, consent, I will explain the risk. Complications can be nerve or vessel injury. It can lead to permanent muscle damage. Then it can have need amputation. If the patient is not, it can lead to infections, need to theatre remain again, return theatre again, plastic reconstruction because you are doing debridement. What are the area of body susceptible to compartment? Which are the areas? Susceptible is extremities as well as abdomen. From patient history, kidney function test, now what has done? Urea is increased, and so it can be, if this is kidney, and it can be pre-renal, post. So pre is vasoconstriction. If suddenly blood is not reaching less, it leads to ischemia and necrosis. Renal, acute tubular necrosis, any pathology inside. Post-renal, myoglobin, because myoglobin is obstructing all this. So another stain can be there of severe muscle pain, dark amber color urine. Investigation revealed high creatinine kinase. Creatinine kinase is increased to very high level. You are suspecting rhabdomyolysis. So this is breakdown of the muscles. So define rhabdomyolysis. Breakdown of the muscle tissue. Muscles are broken down. Myoglobin is entering into circulation. So it is oxygen binding protein, O2 binding protein in the muscles. So what are the other causes? What can lead to? This is skeletal muscle trauma, massive burns, crush injuries, decreased temperature, hypothermia, or reperfusion injury, and sometimes prolonged exercises may lead to. Now, what is ischemic reperfusion? Ischemic reperfusion. So what is there? Reperfusion injury. Ischemic areas which was supposed to be, and suddenly when circulation starts, reperfusion of the ischemia results in washing of metabolites of dead air into circulation. So what happens? These metabolites, they enter into circulation. Laboratory findings, what you find in lab investigation, creatinine kinase, this is 5 times the normal, 5 times. Lactate dehydrogenase, this is again increase. And what electrolytes? Potassium increase, phosphate increase, uracemia is increase, and calcium is going down, hypocalcemia, and myoglobin urea. So how would you like to manage this patient? Again, this is again by the ATLS protocol. You do A, B, C, D, E. So fluid resuscitation, circulation fluid resuscitation. Here you have to hydrate. Hydration, it has to be very high. Output should be more than 300 ml per hour. Then mannitol, diuretics has to be given. Mannitol. Then osmotic diuretic to wash the toxins. Toxins has to be washed out. Then alkalization of urine by giving soda bicarb. So if hyperkalemia is there, potassium is raised to high level, you have to manage accordingly. ECG monitoring has to be done, electrolytes has to be checked, urine output has to be monitored, creatinine kinase 6 to 12 hours has to be checked, LDH, myoglobin in the urine, and compartment pressure. So how do alkalization urine done? It is by sodium bicarbonate. Why it's important? Renal damage to prevent. Myoglobin cast. So it has to be prevented. So what is the investigation? You do urine analysis. The examiner show you the urine analysis, and abnormality is blood plus. So there is blood in the urine. Is it really blood? No, this is myoglobin. So in the abdomyolysis, it's myoglobin. Examiner, because of metabolic acidity, he said why it's high. Potassium is high. So potassium will be raised 7.5. Why it is high? Again he says, since the patient is in hypovolemic status, RAS activation is there, sodium, salt and water. So renin angiotensin activating system. So that causes sodium, water to go in, and potassium so to